Welcome to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Through expert discussions and insights, this podcast will feature information that can help physicians of all specialties address the epidemic of opioid overdoses. Free CME is available. I'm Dr. Bobby Mukkamala, board-certified otolaryngologist, head and neck surgeon, and a member of the American Medical Association's Board of Trustees. Addressing the physical, psychological, social, and spiritual needs of dying patients includes management of their pain. But how have increasing concerns and policies that target opioid misuse impacted their pain management options? Joining me in this discussion is Dr. Chad Kollas. Dr. Kollas has served as the medical director for palliative and supportive medicine at Orlando Cancer Institute in Orlando, Florida, for over 20 years. Dr. Kollas has advocated for balanced opioid policy and maintaining medically legitimate access to controlled pain medications as part of his advocacy work with the American Medical Association and the American Academy of Hospice and Palliative Medicine. Welcome, Dr. Kollas.
Thank you very much for having me today. I appreciate it.
Thanks for being here. So can you share with our listeners a little bit about your work in pain management in end-of-life care?
Sure. What I do currently is to work as an outpatient palliative care physician in Orlando, as you mentioned. Earlier in my career in hospice and palliative medicine, I did some inpatient care as well, including inpatient palliative care unit work. But I've been doing this work now for 25 years in Orlando. Before that, I was in internal medicine. I worked for a while at Geisinger Clinic in Danville, Pennsylvania, and I worked in Atlanta. But the focus of my work, as you mentioned, has been the palliative care work that I've done for the last 20 to 25 years. More recently, I was lead author on a research article published in the Journal of Palliative Medicine in August 2023, which has bearing on what we're talking about today. We presented evidence about the benefits of long-term opioid therapy for patients with chronic pain in outpatient palliative medicine clinic. And I've published some other articles about opioid policy and clinical issues in palliative care. And that includes an Oxford textbook chapter on medical decision-making and end of life.
Thank you for joining us. So can you share an overview of opioid use in end-of-life care? What's the role of opioids in end-of-life care as you're experiencing now?
So let me help to frame a little. It's important to distinguish between the larger umbrella of palliative care and the more limited idea of end-of-life care or hospice care. With that in mind, and I'll talk more in detail about that in a little bit, we use opioid therapy to control severe pain from things like cancer progression or when people have dyspnea at the end of life. Low-dose opioid therapy is very useful in helping with the distressing symptoms that occur near the end of life. This applies to patients not just with cancer, but also emphysema and heart failure. Patients with other illnesses often develop pain at the end of life and derive some reduction in suffering from using opioid therapy. But the thing that I wanted to keep in mind was, again, palliative care is the umbrella, end-of-life care is a part of what we do.
And on that note, can you explain a little bit more about the nuance between using opioids for pain management in palliative versus hospice care? It's often mistakenly used interchangeably, I think.
Right. So in the United States, hospice care is defined by the Medicare hospice benefit, and it's really care that's reserved for patients in the last 6 months of their life expectancy when they have a terminal or life-threatening illness. And for many patients, that's just the last phase of their palliative care. In palliative care, we're basically covering up patients' symptoms in a way that improves their quality of life when they're seriously ill. Palliative care is meant for patients in all stages of illness when they have a serious or terminal illness or condition. The hospice part and the end of life part. So hospice is last 6 months. End of life is probably even when patients have a shorter amount of time than that, like days to weeks. Particularly with regard to that end of life time, opioid therapy is useful in treating pain and other distressing symptoms like shortness of breath. That's probably the biggest role that we have in end of life care for opioid therapy.
Are there societal biases that impact effective pain management in end-of-life care, including utilizing opioids?
Sure. If you look at the world of chronic pain and opioid use disorder and you made a Venn diagram, you'd have two large circles with a small area of overlap for patients that have both chronic pain issues and issues with opioid use disorder or other substance abuse issues. That overlap is a challenging area for us to take care of. So there's both stigma for patients that have opioid use disorder, and I'm using that term rather than saying opioid addiction. And there's also stigma for patients with chronic pain that's sort of been produced by things that are going on in our media. Both of those groups often have difficulty accessing the care that they need. So part of what we're trying to do, not just in the field of palliative medicine, but the American Medical Association in particular, is making sure that people have access to the care that they need and get around that stigma so that we take good care of patients. So to sort of give you a real life example of the problem where there's this intersection between the world of opioid use disorder and chronic pain. I had a patient who had been using heroin regularly and was diagnosed with pancreatic cancer, actually late stage pancreatic cancer. It was stage 4 by the time that he was diagnosed. And he had difficulty with severe abdominal pain, was referred to our palliative medicine clinic. He had previously been referred to a methadone clinic to try to treat his opioid use disorder, but the methadone clinic didn't want to continue that care because they use a different dosing approach when they're treating opioid use disorder than we would use in palliative medicine. So he didn't know what to do. He went to the oncology people. They said they didn't want to prescribe a controlled pain medication to him because of his persistent heroin use. And he had actually been using at that point in his illness heroin to treat his cancer pain. His parents kicked him out of the house because of the heroin use. He got referred to us. His sister brought him in, and she said, listen, I'll help manage his medications and make sure that he takes them in a way that's responsible if that's what we need to do to make this work. And that was a big help. But ultimately, we put him on a schedule where he was using methadone every 8 hours with occasional use of low-dose oxycodone for breakthrough pain. And that obviated his need to use heroin. He's like, I have no desire when I'm taking this medication to go out and use drugs. My pain's well controlled. And his family was actually happy that he was no longer using heroin. And everybody got together and said, gee, it's silly that we were letting this divide us in the way that it did. So he eventually, even though he died from his illness, it gave him an opportunity to sort of reconcile with his family. So that's, to me, that's a good example of what happens at that intersection of addiction and chronic pain. With regard to the oncology colleagues and their reluctance to prescribe controlled pain medicine, I get that. Physicians, they're wary of opioid therapy, even in the setting sometimes when they have severe cancer pain. I'll mention, well, I think you might benefit from a fentanyl patch. And a patient would say something like, oh, no, I heard people are dying from fentanyl overdoses. I don't want to be on that medication, because the media has conflated illicit fentanyl with prescription medicines. That's one of the things that's a challenge. Another patient example, one of my patients was reluctant to use fentanyl. She's a lady who has breast cancer. And she said, I'm glad you talked me into the fentanyl patches. And I hate talking patients into any kind of care. I'd rather them be the ones guiding their care. I make recommendations. But she said, my pain is so much better. I can actually do the things that I want to do now. And I was scared of this medication just because I had a misunderstanding about it. And she's like, thank you for being persistent about it. So I do think there's a lot going on because of that. Two distinct populations of patients and overlap, but basically what you have to do is each group needs to be treated in the way that works for them.
Yeah, thank you. Those real world examples really illustrate the decisions that need to be made in collaboration with those patients. So how the policies that were aimed at preventing opioid misuse had the unintended consequence of reducing access to opioids at the end of life. Policies that were, again, well-intended, but with these consequences.
I think that most of the clinicians, policymakers, and scientists who were involved in crafting the 2016 opioid guideline from the CDC were really making a well-intentioned effort to address the opioid crisis, which I would now describe more accurately as an overdose crisis driven by illicit fentanylogs. But the idea at that point in time that reducing opioid prescribing should reduce opioid deaths made sense because there was such an increase in opioid prescribing in the late 1990s. And in the early part of this crisis, that looked like, prescriptions drugs are what's driving this. Over time, probably around 2010, when OxyContin was reformulated, it led to change in what was going on as far as what was driving overdose deaths. At that point, heroin then became more available in that it was less expensive. The reformulated OxyContin was harder for patients to crush, so they moved to whatever the next drug, those that had opioid use disorder. And that's ultimately one of the things that changed what was going on. So the good intentions were, create a drug that's safer to use, but again, it created a situation that became more dangerous for patients. The other thing is, in Florida, there was a major change in law around 2012 or 2013 in which the state eliminated rogue paid clinics. They're also known as pill mills commonly. And that reduced the diversion of legal medications along the eastern coast of the United States, but actually created then a problem with a shortage of medication that could be diverted and used in an illegal way. And that also was a policy decision that was meant to improve safety, but actually led to a more dangerous supply of medication. So, and then one of the other aspects that we're seeing going on lately is that the DEA has over time reduced production quotas for manufacturing of opioid medications based on reductions in prescribing. So it's like, oh yeah, last year we didn't prescribe as much, so we're not going to make as much medication next year. And that's had the net effect of having less access to pain medication in a way that's driven people to other alternatives. So either, it doesn't matter if you have chronic pain or if you have opioid use disorder, if those are the medications that are meeting what you perceive your needs to be, you're going to try to get them. And patients who can't get access to pain medications through their physician, will reach out to other sources like friends or relatives that might not have medications that are legitimate. They might be counterfeit pills that contain illicit fentanyl instead of containing controlled amounts of medications that were created by a pharmaceutical manufacturer. The deaths that have occurred is more related to a dangerous supply than in really anything else. And it was a dangerous supply that well-intentioned policies created.
Got it. Thanks. Yep. So shifting gears a little bit to the principles of pain management in end-of-life care, can you start us off with an overview of pain management in general and how they apply specifically to chronic pain or painful conditions that patients experience at the end of life?
Sure. Just some general principle ideas that'll help people understand what are the things that we should be focused on. I think the most important thing to keep in mind, and when we're using opioid therapy, first of all, most patients aren't going to get to opioid therapy as their first choice. They're going to be using other medications that are non-opioid medications appropriately as they try to control their pain. So they'll use things like acetaminophen, non-steroidal anti-inflammatory drugs. They might be using lower potency opioids initially, and that's appropriate to have a stepped care approach to pain relief. By the time they're seeing me, people have already tried those things. They've tried non-medication type therapies like physical therapy, heat and cold packs. We actually have a law in Florida that requires us to discuss with patients before they're prescribed opioid medications all the other treatments that are available to them. It makes it feel like opioids are a treatment of last resort. I don't know that that's the case because there are situations where you might use them sooner for people that have serious cancer pain. But ultimately, what you're trying to do is once you get to the place where you've tried other things and you now need to use opioid therapy, what guides your care is that you're looking to find the lowest effective dose that treats the patient's pain in a way that's optimal for them and allows them to do the things in their life that they like to do functionally, but also the lowest effective dose to mitigate risks associated with their treatment. And an important thing to keep in mind is we're not looking in the population of patients with cancer pain, in cancer survivors with pain, in sickle cell patients. We're not trying to get people to a place where they're pain-free. We're trying to get them to a place where their pain's well enough controlled that they can have good quality of life and do the things functionally that they would like to do. That good pain care often involves a multimodal approach to pain management, and it also involves that we communicate not just with patients, but sometimes with their families to help them understand, why are we making the treatment decisions that we're making. It also helps to have an interprofessional care team, particularly on the spectrum of palliative care when you're talking about end of life, so that you can deal with some of the other psychological, social, spiritual, and existential needs that patients have when they're dying. So that's sort of the general approach to, okay, how do I manage pain care in palliative care? Again, focusing on trying to reach the lowest effective dose. And one other thing to emphasize is the whole process is one of shared decision making with patients so that they can make informed decisions about their care in a way that they gain the most benefit and you can keep them as safe as possible.
Thanks. It seems that the nature of this can be so subjective. So just to focus on the assessment of that pain, can you give us an overview of what that pain assessment looks like? What role does the subjectivity of pain play in that pain assessment at the time of the end of life?
Sure. So you make a good point about subjectivity of pain. So a pain rating for one patient may mean something entirely different for another. A good example comes from during my residency training in Hershey, Pennsylvania, which is close to Lancaster County, home of the Amish. And we had a Amish farmer come in who was painting his barn, and his presenting symptom at the desk was, "Oh, I have just a little chest pain." And so they didn't hurry about getting him in a room. When they finally did, he had tombstone changes on his EKG, ST elevation that was classic for like a gigantic anterior myocardial infarction. He was having the big one. And he was in tremendous pain, but he downplayed it because culturally, that was the thing that he had grown up with. So there's big differences culturally. There's also differences when we're assessing pain when you take it into account factors like anxiety, which increases pain perception. And it's very important when you think about anxiety and pain that there's been a lot of buzz on social media about the concept of catastrophizing, and some patients who have chronic pain feel kind of medically gaslit when we talk about the term. But basically, it's a real clinical phenomenon that we need to take into account when we're determining appropriate doses for opioid therapy. So people worry when they're in severe pain, particularly if you look at the cancer patients. To them, severe pain often means progression of their disease. That makes them anxious. Their pain perception increases, and it's an ugly cycle. So part of the assessment involves looking at those factors and educating patients about what are the things that can be wrapped up into their own assessment of their pain. Probably the most reliable thing that we still use as a tool, if you want to talk about an objective metric, is the pain scale, where we tell patients 0 out of 10 is no pain and 10 out of 10 is the worst pain you've experienced. And I don't think that's an ideal way to do it. I think it would be great if we had something that was more objective, but it's probably the best tool that we have. For better or worse, it's the gold standard. When we did our article that we published in Journal of Palliative Medicine, and we looked at what were the things that we could do for pain assessment, that was what worked the best. But again, there's a lot of context to pain. It's subjective, and this is a matter of figuring out each individual's particular way of expressing themselves and doing what's right for them in terms of managing their pain.
Thanks. And you mentioned the scale. So is there a different way to look at it? Like, how does end of life measures or metrics vary from those that aren't at the end of life versus those that are?
That's a great question. And the problem is, within our field, I don't think that there's any unanimity about what's the best metric to assess either symptoms at the end of life, pain at the end of life, quality of life. There are many different scales. One of the most commonly used is an older scale called the Edmonton Symptom Assessment Scale, ESAS. No one's gotten together and say, okay, this is what we should use to measure quality of life, to measure pain. We have a variety of measurements that we use. Unfortunately, there's not one metric. What we do know, however, it's very important in terms of the evidence base that we need to integrate palliative care timely into patients' care, particularly outpatient palliative care, because randomized controlled trials have demonstrated that palliative care improves multiple clinical outcomes and reduces the cost of care, as well as reducing the number of aggressive interventions that patients may not want near the end of their life. Again, we're trying to create goal concordant care with our patients. We need to assess what are the things that they're looking for. So the most important metric of quality of life, and it sounds sort of trite, but the most important measure of quality of life is what the patient tells you is important to them with regard to their quality of life. And you want to offer them care that manages symptoms like pain and other distress in a way that helps them to reach their personal goal. What is it that looks like a win for you in a situation that, particularly at end of life, seems like a very bad situation?
So shifting gears a little bit. So when contemplating pain management in these patients, how do you determine if a patient receiving palliative care is misusing their opioids?
So people, different places do that in different ways. But I can tell you from our article, because we had to sit down and think hard about in a operational way, okay, well, how do we assess that? So the way that we do it was the first step is assessing the patient's adherence to their pain regimen and trying to clarify deviations from their prescribed medications. So, are you taking your medicines the way that you're supposed to be? Now, if somebody ran out of their medicine early, that doesn't necessarily mean that there's a problem there in terms of aberrant use. It could also be because someone's having difficulty with pain. So it's very important to assess the context when you're figuring out, okay, how often are you taking your pain medicine? For people who are interested in a more objective metric, there's a tool called the revised opioid risk tool. It's revised because the original opioid risk tool had questions that dealt with having a history of sexual abuse at a young age that was sort of slanted against victims of sexual assault in a way that it was biased against them in terms of them receiving opioid therapy. There's the revised version that's been validated in clinical studies that basically looks at the patient's risk factors related to other substance use and things in their lives that might put them at increased risk for opioid misuse. And then in our state, the prescription drug monitoring program is actually a good tool. It's not the only tool to use when you're making the assessment, but it gives you the opportunity to see if there's other people that are prescribing for the patients. Frankly, I use it as an information source because a lot of people come in and they don't know the strength of the medication that they've been taking, or they don't know what medicines that they've taken in the past that were effective for them. And those are all things that we can find there. When we did a study a few years ago, we looked at what was the incidence of people who were doctor shopping in Florida when the PDMP mandatory query went into place in July of 2018. For the first 3 months, we tracked all the patients that were having queries done, what we found in their query, what their dose of medication was, what their pain rating was, and ultimately found out that there was little to no physician shopping. Most of the multiple prescriptions that we saw were related to the structure of our healthcare system and how someone who had a new diagnosis of cancer but didn't know that they had it would first see their primary care physician. Say, you're talking about a patient that has pancreatic cancer, and they go to their primary care physician complaining of epigastric abdominal pain, and then they would get referred to a gastroenterologist who would do an upper endoscopy, and they may not find anything. And they might say, I'm not going to be the one to prescribe your medicine. And the person would go back to their PCP, and the PCP might say, okay, I can give you a short-term supply of opioid medication because your pain's severe, but we don't know what's causing it. And they'd end up in the ER and they'd get a CT, and the CT would show a pancreatic tumor. And then the ER doc would be, well, it looks like you have a problem that you have to have worked out more. And they'd continue to see other specialists until probably 6 or 7 doctors into their care, they were finally getting to us. And then that gave them somebody that would give them care consistently. The context of the patient's illness is important when you're looking at aberrancy, but there are metrics that are useful. And the most important thing is understanding the patient's story.
Yeah, and this is where it gets a little complicated, but can you talk about pain management for a dying patient who has an opioid use disorder? How do you balance pain management benefits with the opioid use disorder risks in the management of their end-of-life pain?
Sure. So I think the center part of this discussion is that when you're considering opioid therapy in any patient, it's about balancing the benefits of the therapy versus the risks of harm to the patient or exposing them to a risk of potential harm. And there's something called palliative sedation. In palliative sedation, you're sedating a patient or giving a patient also pain medications to make them comfortable, usually when they have refractory suffering. There's a lot of misunderstanding about what does that look like exactly, but ultimately the reason why we can do it ethically is because we're doing it in a way that takes into account 2 concepts. The first is the concept of justification. That is, when someone has pain that is that severe that there are no other treatments relieving their pain, and they may need to be on an IV drip of opioid medication with or without some other sedating medicine, how badly they're suffering has some influence on what treatment is justified in their care. And the other concept is one called proportionality, meaning as you're dosing medicines that have negative side effects, you're careful about your dosing and you're doing it in a way where you're giving a small amount, looking at a clinical response and seeing, okay, did that help? Do we need to use more? Is the patient having difficulty with side effects? Let's continue to reassess, make adjustments in our treatment plan, and then reassess again. It's sort of the circle in palliative medicine where you have a plan, you implement the plan, you see how it goes, reassess, and see, do we need to make adjustments in medications? It's very helpful that way. Just to sort of tie up palliative sedation, a good example of how there can be a disconnect between patients and their families' expectations of what's going to happen. There was a patient who had ALS and had been ventilator dependent at home, and he had made the decision that he no longer wanted to be on a ventilator and that he wanted to simply let his disease take its natural course. So he was brought into our inpatient palliative care unit, and we put him on like a low-dose morphine drip, and he was also on some medications to help with any anxiety that he might have because of air hunger. And so we got him to a place where he was comfortable and like sort of a quasi-sleeping state. He wasn't really interactive, but at the same point, it wasn't like he was in a deep coma. And his family's like, well, isn't he going to die? And we said, well, yeah, at some point. But our goal was just to get him to a place where he didn't have air hunger, he wasn't gasping for breath, that he was comfortable. And they're like, well, he looks very comfortable. It's light sleep. And I said, that's sort of what we were shooting for. And they asked, well, can we talk to him? And I'm like, well, sure, you can talk to him. And I think that he probably has some idea that there are people who are there with him who love him. And they did. They would talk with him. And I think it took almost 2 days until he died peacefully and quietly. But their expectation was that we were going to be giving him pain medicine quickly and then he would die from the pain medicine. But instead, it was much more about letting his illness run its natural course and trying to be careful about the medicines. It was justified because he was suffering so much. He would have had terrible air hunger without the medications, but using them in a proportional way so that we were minimizing risks of doing something either ethically impermissible or harming him. And I think that's what lies at the center of taking care of patients who are dying and have either, issues with opioid use disorder or other issues that make you concerned.
Yeah, such a great story to illustrate those ethical concerns and some common misconceptions even with that family. So as we wrap up here and bring our discussion to a close, what are the main takeaways you'd like our listeners to remember most? Maybe just a few key points.
The things that I think that are important for people to understand is that opioid therapy, even in the long term, is safe and effective for many patients, not for all patients, but for many patients. Some patients are going to benefit more than others. I happen to work in a population of patients that do benefit very much from opioid therapy. The second part is we can improve benefits and reduce risks of opioid therapy by focusing on right prescribing, not just focusing on blind opioid reductionism and like just saying, oh, opioids are bad. We want to take everybody off of opioid medications, even when they're deriving benefit from them, because we see that there's harms related to doing that. When people are tapered off their pain medication non-consensually or too rapidly, it increases their risk of suicide or having an overdose from illicit medications. We can do opioid therapy in a way that maximizes benefits and minimizes risk. And then the other thing I would say is, compassionate pain care has to be individualized, and it has to be done in a way that embraces shared decision making with an emphasis on informed discussions with our patients so that we can achieve goal concordant care. Ultimately, they're the ones who decide what's right about, their quality of life. What are the things that, for them, define a good quality of life? And we need to have those discussions so that we can make that happen using our knowledge as physicians and healers, and in a way that puts them in the best position so that they can have the best quality of life that's possible. Because, the reason why I transitioned from doing internal medicine palliative care is I realized everybody dies. And if I'm going to be judged as a physician on whether or not I save everyone, I'm doomed to fail if that's the goal. But I can, as a physician doing palliative medicine, make sure that people have the best quality of life that's possible for them.
Mm-hmm. Yes, indeed. What would you like to see that would make the most positive difference in the lives of dying patients and the physicians who manage their pain? What's your call to action?
Opioid reductionism is not the way forward. Too many of my colleagues in pain care have stayed quiet instead of advocating for their patients for right prescribing and goal concordant care, even though they practice that way. So, there's a whole bunch of people who do the right thing out in the real world. I'm surrounded by physicians that know what's the right way to take care of patients' pain, and they do it in a compassionate way. And what I would like to see is more physicians nationally who have that kind of knowledge and that kind of training step up and do the things that they're called to do, and worry less about, I might get in trouble and lose my license, and worry more about what's the right thing to do by my patient. So that's what I would like to see going forward. Over the last several years, the AMA has really been a leader in turning the situation in our country around, which culminated, I think, in the adoption of the new 2022 CDC guideline, which is a much better improvement over what was in place in 2016. And that's the type of commitment to offering compassionate pain care that I'd like to see. And I want the folks that can do it, and they're out there, I want them to do the right thing.
Thank you so much for your leadership there to help us to get to the right thing. And thank you for joining us today, Dr. Kollas. We really appreciate your insights and experience addressing palliative and end-of-life pain management. I'm sure that our listeners have a much better understanding of the role that opioids can play in providing relief in palliative and hospice care in those settings and the differences between them.
Well, thanks very much for having me. I really appreciate it. Enjoyed the time.
Thanks to everyone for listening, and we'll see you next time. Thank you for listening to the American Medical Association Physician Education Podcast on the opioid overdose epidemic. Make sure you tune in to other episodes of this series to learn more about opioid use disorder, and harm reduction. Visit the Resources tab to learn more. Complete the quiz to earn CME.